everyone, and so glad to be here, and I'm very happy to welcome our delegates from SOAPC. I'm going to just give a brief overview of our institution and what we do here with regards to onco-anesthesia. Well, a brief introduction of our institution. We are a teaching hospital, a referral center. We provide advanced tertiary care. We have a very high patient load of around 12 to 14,000 per day. And we have inpatients around 3,800 beds, mostly spread in Main and Ranipet campus. We have been providing oncological services since 1960s. We get patients with complex pathology, advanced disease, recurrent disease, multi-site disease, patients who have received cancer treatment elsewhere. So, though we do not have a surgical oncology department per se, our entire spectrum of cancer surgeries are managed by the surgical units in a site-specific manner of distribution. So after year 2000, the cancer care became more streamlined and focused as the surgical departments further subspecialized into highly specific units based on specific anatomic regions. And anesthesia also for oncosurgeries followed similar pattern of evolution. So we have been doing oncosurgeries and we have been providing anesthesia for these surgeries, but our departments have been formally established after 2000, and surgical oncology was divided into various units from 2003 onwards, and Department of Gynecological Oncology and Urological Oncology were established in 2010 and 20 respectively. So a little bit about our department. Our Department of Anesthesia was established in year 1958 with just 3 consultants. Now we have grown to become a department with 101 consultants, including senior residents, 99 postgraduates, 120 operating room technologists. We have around 80 operating rooms and 10 non-operating room locations where we provide our anesthetic services. And we do around 220 cases per day. So we have different anesthesia teams who manage cancer surgeries depending on the site. So it's not moving. So our department is divided into 6 units. We have the 6th unit is a trauma unit. Our whole load of oncological cases are handled by unit 1 to 5. And we also have a department of cardiac anesthesia and neuroanesthesia, which do their cases pertaining to their areas. So most of the abdominal and pelvic surgeries, we anesthetize for those cases where unit 1, 3, and 5 are involved. So this is a snapshot of our whole lot of where we provide anesthesia for oncological operations. We have around, as you can see, we have whole lot of areas, the whole of anatomical areas of the body covered here. You can see that we have wide variety of cases, and the amount of surgeries and anesthesia we provide for those surgeries are around 7,000 per year. And this is over and above actually what we, over and above these 7,000, we also provide anesthesia for interventional procedures like tumor ablation and chemoradioablation as well. So over the next 2 slides, I'll just show you some pictures of the kind of complex advanced cases we deal with here. These are some of the pictures of head and neck cases, laryngeal tumors, oral cancers, base of tongue tumors, which pose, a challenge for us to secure the airway. The last picture shows airway exchange catheter into the trachea for an open airway, a tubeless anesthesia. So we deal with very complex cases as well. This is a picture showing, variety of abdominal and pelvic tumors which have been undertaken in our department, and we have provided anesthesia for these kind of cases as well. Huge retroperitoneal sarcomas, pelvic girdle tumors. We've also had tumor resections, hepatectomies with IVC reconstruction, and a whole lot of things. So this is a picture showing we do cytoreductive surgeries and HIPEC. This is done for pseudomyxoma peritonei. So these kind of cases are quite challenging and require quite a lot of expertise and skill, which we do in our institution here. And this is our robotic theater where we do minimally invasive cancer resections. So there is a radical prostatectomy going on, and then we have minimally invasive esophagectomies as well. So oncoanesthesia is as you all know, is an emerging subspecialty focusing on complex needs of cancer patients. In CMC, we have a wide spectrum of and high volume of tumors, high volumes of patients, wide spectrum of tumors, and we provide a comprehensive, specialized perioperative care for our patients. As you all know, the cancer biology, side effects of chemoradiation, and major surgical stress, all these contribute to the challenges we face in anesthetizing these patients. So moreover, our goal now is not just to keep the patients asleep, it goes beyond that, emphasizing on smooth recovery and long-term oncological outcomes as well. So it's not just intraoperatively we take care of, we also are involved in preoperative optimization as well as postoperative care. So along with pre-anesthesia clinic, for preoperative optimization, we also have high-risk clinic, specifically for patients with significant comorbidities. Recently, Department of Medicine Unit 2 has opened a multimorbidity clinic, which works alongside with pre-anesthesia clinic and high-risk clinic in planning the pre-optimization and rehabilitation of patients. We do also have multidisciplinary meetings apart from the tumor board meetings. Currently, our consultant anesthetists and surgeons, they discuss prior to the surgery and anesthesia the complex cases which is happening now. But we hope to have a formal MDT involving all these teams, anesthesia team, surgical team, multimorbidity specialists, as well as cancer specialist nurses, to formally discuss and document a plan and pathway for these kind of patients. I think some of our units have already started doing it. So intraoperatively, we have advanced monitoring techniques, like we have invasive hemodynamic monitoring, neuromonitoring. We do MEP, SSEP for neurotumors. We also do cardiac output monitoring for high-risk cases to tailor fluid management. We also have blood conservation strategies in place. We have a cell saver, and we also do normovolumic hemodilution and autologous transfusion where required. We have a goal-directed fluid management policy. We also have difficult airway management protocols in place, and we aggressively maintain the temperature of the patient using varied warming devices. And we also give epidural and peripheral nerve blocks for pain management along with PCAs. Multimodal analgesia is what we follow. So these are some of the pictures of our theaters where we have been using this. There is a picture of a flow track we use for cardiac output monitoring, various target control infusion pumps as well. So for our difficult airway, we have our difficult airway aids. We use even jet ventilator for open airways, the tubeless anesthesia. We have airway exchange catheters, and the usual fiber optic and video laryngoscopes. So post-operatively, we have enhanced recovery protocols in place, and to facilitate this, we use multimodal analgesia, we use epidurals, peripheral nerve blocks, PCAs. We have a dedicated pain team to follow up these patients. And we also have a good critical care service which helps us in taking care of our patients post-operatively. So just to summarize, I'd like to end with saying that oncoanesthesia is a joint initiative of the entire department. We have a wide spectrum and a large volume and complex cases in CMC, and we have faculty with special interest as well, and we are very happy to inaugurate our Vellore chapter today with the Society of Oncoanesthesia and Perioperative Care, and we hope to start a training program coordinated by Unit 1 and 3 jointly. Thank you very much.
I also request Dr. Ekta Rai, our previous head and senior professor, to hand over the memento to Dr. Bernis.